A new risk calculator that will reduce statin usage? Well, let's take a look at that. Stay tuned. Recently, this article from the Journal of the American Medical Association network hit my inbox, and a few of my viewers sent me links to it, so it's great that we have such an active and participating viewership here. I really appreciate that. And I thought this was worth looking at. This is a secondary source. It's an article about a study. For many people, this is all they're going to see. They're not going to read the original study. It's a 23-page journal article, very difficult to read. The title of it was New Cardiovascular Disease Risk Calculator Could Eliminate the Need for Statins for Millions. Now, I have some heartburn with the title. I'll get back to that at the end of the video. So let's go on and take a look at it. First, I want to point out there's a lot of statistics in this article, but they're not really given context. It gets very confusing. They're intersecting groups and everything else. But I've often quoted 93 million as the number of patients in the United States on statins, and that was as of 2019. And I got that figure from an article in a Saudi pharmacological journal for work that was done in Florida. And I've just kind of taken that at face value. It seemed to be pretty well done. But this article starts out by saying there are 45 million patients in the United States on statins. Now, there are various explanations, but we really want to know which one is it. I actually did go back to ChatGPT and see what it was going to offer, and it said, well, this new calculator just reduced the number of people who are on statins, which is ridiculous because this calculator is not in widespread use yet. It's not even into the guidelines, so it's absurd to think that that was a reason for the difference in the 93 million versus the 45 million figure. So which one is right? Well, I don't know. This article just drives home how shaky the statistics are, so I'm going to be a little more careful in the future, especially when I quote the statistics. I'll caveat it with whatever's appropriate. They also talk about primary prevention, and they're saying this new calculator will reduce the eligible patients for primary prevention from 45.4 million down to 28.3 million. That's not the same 45 million as we're talking about as far as people who are on statins. What this ends up saying is that, well, there's a 17 million person reduction in the number of people on primary prevention who are eligible for statins, but of those 17 million, only 4.1 million of them are currently taking statins. And in this article, they also said about that 4.1 million people who may be getting off statins if they were to follow through with this. This would set up important but potentially challenging conversations with patients. And then they didn't say why the conversations would be challenging. Is it because the patients are going to say, no, I want to be on the statins because it's keeping me safe? Or would it be patients saying, you put me through this hell of being on statins and now you're telling me it's unnecessary? In that case, the doctor's going to be in a position of saying, well, we have new information and this is the new guidelines. So that's going to be interesting how that all falls out. This article had a bunch of what I call miscellanea, just different things in there that I found interesting. The first one, now it's saying 29.3 million people currently classified as an intermediate risk will be reclassified. About a quarter of them to low 10-year risk of cardiovascular event, and about 46% of them to borderline risk. Now, they didn't say what constituted low, what constituted borderline. Will the people on borderline be recommended statins or will they not? I don't know. The statistics were a hodgepodge. I think the article was just written with, we'll pull out some interesting things and we'll throw some numbers behind it, and that'll pique people's curiosity or something. And that 29.3 million people intersects with all the other different millions that we've been talking about, but it doesn't match up with any group exactly. The 2018 pool cohort equation seems to have been ignored, so this wasn't in the article. Its absence to me was telling. They only mentioned the 2013 pool cohort equation, so the 2018 one just never got any traction, which is kind of weird because this prevent calculator gave me very similar numbers, and we'll get to that. This new calculator includes the eGFR as a new input. That is a measure of kidney health, basically, and you usually find it in your comprehensive metabolic panel if you get a comprehensive metabolic panel, which is fairly common, I think, because I get it all the time, and you'll see that figure in there, so you can plug that into the prevent calculator. Prevent is the name of the new risk calculator. There's a link to it in the description. They also include HbA1c, which I think is great because while HbA1c isn't a perfect indicator of type 2 diabetes, at least it distinguishes between somebody who is barely diabetic, maybe has an HbA1c of 6.5 versus somebody who's got a 14 HbA1c. Those are very different, and the existing calculators just make it a yes/no, and they make no distinction between somebody who's extremely diabetic and somebody who is just barely over the edge and maybe can recover from it by changing their diet and lifestyle. This UACR is a ratio that comes from a urine test. The two components to it, that's albumin, if I'm pronouncing it right, and I think it's creatine. And by the way, you'll notice that triglycerides are just not an input to this calculator, which just once again baffles me considerably. It is an array of confusing statistics in this article. For example, they have this statement: only 44% of patients in the study group eligible for primary prevention reported using the drugs. How does that jibe with the earlier statement that 17 million people were going to no longer be eligible, but that only affected 4.1 million of them because all the rest weren't taking statins anyway? Well, that's 25%. Now they're saying 44%. This was a small group. It was less than 4,000 patients, which to me really isn't robust enough to say that this calculator is going to be better than any other calculator. But since it's giving us lower numbers and they're saying it's more accurate, let's go with it for now. Finally, they mentioned that new cholesterol guidelines were to be released likely in 2025 with guidelines for primary prevention of cardiovascular disease after that. So I'm really looking forward to seeing those. There is a fundamental problem, however, with all these risk calculators when it comes to risk assessments and accuracy. I mean, what does it mean to be more accurate? When you're told, for example, you have a 7% risk of a cardiovascular event in the next 10 years, what does that really mean? Well, it really means that if there were 100 people just like you and we threw you all into a group and you all had a 7% risk, well, 7 of you after 10 years would have had a cardiovascular event and the other 93 of you wouldn't. But what does that mean for an individual? An individual really has either a 0% 10-year risk or a 100% 10-year risk. 7 of the people in this group of 100 have a 100% 10-year risk and the other 93 have a 0% 10-year risk. We just don't know it. That 7% is a measure of our lack of knowledge, and it's not a very useful number for an individual. Now you can say, well, the math works out the same, but it's really not useful for an individual. How are you going to really use this? Are you going to look at this and say, should I take this drug that there's a high chance it's going to really mess me up? Or do I take it and see if it messes me up and then get off it if it does? It would be nice if these new risk calculators could do something like this, and that is break this group of 100 people into 2 groups. The 93 who have a 0% risk and the 7 who have a 100% risk. That's what we really want to see. So then we could tell somebody, you're good to go, don't worry about it, or you really need to do something, change your lifestyle, take some medication, whatever it is to reduce your cardiovascular risk. Now that's probably a pipe dream on my part. Inputs to these calculators are just limited to the widely available data, such as HbA1c, obviously total cholesterol, HDL. Trigs are widely available, they're ignoring them. I don't know why. It doesn't make a distinction between, is the patient a lean mass hyperresponder, or exercises regularly, or has a clean carotid intima media thickness test result, or has a coronary artery calcium score, a CAC score of 0. Some calculators do actually include that. So if these things were considered, maybe we could get closer to this. Maybe we could get to this intermediate state where we broke the group into 90 patients who have very low risk. One of them might still end up having a cardiovascular event in there. And 10 people who have a very high risk, 60%. And if you were told you had a 60% chance of a cardiovascular event in the next 10 years, yeah, you would want to do something about that. So this is what we really want to get to. At the very least, some intermediate point. But the calculators, all they're doing is they're refining the predicting how many people out of 100 are going to end up with a cardiovascular event. And for the lower numbers, they're really not useful to the individual. So now let's look at the headline. New cardiovascular risk calculator could eliminate the need for statins for millions. And I said I had some heartburn with this headline. It's not the need for statins phrase in there. Yeah, I actually do have some heartburn with that. But I'm setting that aside. Let's just accept that there is such a thing as a need for statin, at least if it's somebody who's at extremely high risk. Let's look at patient A, who has a 12.5% 10-year cardiovascular risk according to the 2013 pooled cohort equation calculator. and for them a statin would be recommended. And then there's patient B who has a 6.9% 10-year risk according to the PREVENT calculator, and for them a statin is not recommended. Guess what? This is the same patient. I put my numbers into these two calculators, and these are the numbers that it gave me. A 1 out of 8 chance that I'm going to have a heart attack in the next 10 years according to the older calculation, or a 1 out of 14 chance, something around that figure, that I'll have a heart attack in the next 10 years. Did this patient ever need statins? The new calculator only opened our eyes to what the actual risk is, notwithstanding the discussion that I just had about how useless that figure is. The patient didn't change. So how could the need have changed simply because we've got a better calculation? This eliminating the need for statin for millions, that really bothers me because it just shows the thought process that the mainstream medical profession is in. They're going to use their numbers and they're going to decide that something is needed based on the numbers. I would have preferred if this article was a little less clickbaity and they had replaced the need for statins to eliminate unnecessary statins for millions. That would really get to the heart of it, because that would acknowledge that a lot of people who are on statins, it's really unnecessary. So in my closing thoughts, I'm really not sure where they're going with this. It's a good thing that they've acknowledged that statins are overprescribed. We're going to have to wait and see what happens with those new guidelines to determine whether they're going in the right direction with that. For example, will they just accept there are going to be fewer people on statins because we have a better calculator? Or are they going to just push the threshold down to keep the same number of people on statins and saying, this is great, now we're going to treat people with lower and lower risks? Will they have adjustable thresholds based on age? For example, somebody who's 40 years old and has a 7.5% cardiovascular event 10-year risk, that figure will compound as time goes by. But if somebody is 80 and they have a 7.5% 10-year risk, they're actually in pretty good shape. They're among the healthiest of 80-year-olds. As much as we don't like to admit it, their risk simply has less time to compound. So there are some squishy statistics out there that say that for somebody in my position, the average white male my age in the United States, for example, has a 20 to 30% chance of having a cardiovascular event over the next 10 years. Even the higher figure from the 2013 pooled cohort equation had me at about half of that. And of course, the new PREVENT calculator has it at about a quarter of that. So if you were to challenge your average doctor and say, hey doc, my risk is far lower than average, why are you trying to put me on these drugs? They would just say that's just a reflection of how poor the health is of the average American or the average person in the world when it comes to cardiovascular risk. And to some degree, maybe they're justified. But it just shows that you're not going to get anywhere with any discussion with a doctor who responds like that. And finally, a lot of doctors simply use 200 milligrams per deciliter for total cholesterol, that's about 5.1 millimoles per liter, or 100 milligrams per deciliter for LDL, which is about, I don't know, 2.5, 2.6 millimoles per liter. They use that as their thresholds. If you're over either of those, well, we're going to put you on a statin. I've had viewers give me their numbers, and because one viewer, for example, was slightly over on both of these, even though they were extremely metabolically healthy, their doctor wanted them on statins. I don't think this new calculator is really going to have much impact on that way of thinking. Let's wait and see. I'm really looking forward to seeing those new guidelines when they come out. When they do, I'll have another video on that. So that's what I've got on this subject. If you appreciate this content, please like, share, subscribe, and comment on this or other topics you'd like me to cover. And if you haven't seen this video, I recommend you take a look at it now. Thanks for listening.